Good morning, everybody. I think everyone's still on morning time. I am Stephanie Mullett. I am the program administrator for the Alagille Syndrome Alliance, and my son, Bryce, had a liver transplant whenever he was about 10 months old, and we got all sorts of things clicking around. My husband was his live liver donor back in 2018. And today we are talking about vaccines and vaccine preventable infections in the pediatric solid organ transplant population. It is my absolute pleasure to introduce this session and introduce one of my personal heroes, Dr. Feldman. Hi. Dr. Feldman is a pediatric transplant hepatologist at Children's Hospital Colorado, and she's the medical director of the Liver Transplant Center at Children's Hospital Colorado, and she's my son's hepatologist, so we absolutely adore her. So I'll be keeping track of the Q&A and things like that. So Dr. Feldman is going to do her presentation first, and then we'll do questions at the end. So thank you.
Thanks, Stephanie, for that wonderful introduction. Can you see all of my slides and hear me okay? Perfect. So thank you to Melissa and the entire organizing committee for inviting me to speak today. It's truly a privilege to get to talk to all of you. And I will say that Stephanie and her son, Bryce, are my heroes too, and a part of my family. And so it's exciting to be introduced by a friend and a family member. Today, I have the unique privilege of getting to talk to you about something that I am incredibly passionate about and perform quite a bit of research on, and that's vaccines and vaccine preventable infections in the pediatric solid organ transplant population. So a couple of goals for us today. First, we want to understand the importance of vaccine preventable infections in the pediatric transplant population. I'm going to go over current transplant vaccine recommendations, both pre and post-transplant. We're going to discuss some of the barriers that are unique to vaccination in the transplant population. And then finally, I'm going to talk to you about some unique solutions, including a mobile phone app that my team has created. So why are transplant recipients at high risk for infection? The main reason is the immunosuppressing medications that we put children on after transplant to help prevent them from losing their graft. Unfortunately, these medications make it harder for the body to screen for and fight against infection. And the medicines that I'm talking about are tacrolimus, sirolimus, Imuran, Cellcept, MMF, and of course, all the various forms of steroids. Additionally, certain children have risk of acquiring a vaccine preventable infection, such as hepatitis B, from their donor. And finally, some children are transplanted early in childhood, and this is true for 50% of pediatric liver transplant recipients, that they're transplanted in the first few years of life, and therefore they may not have had time to complete their full set of childhood immunizations before transplant. So the question that my team asked is, are children who undergo transplant just at risk for infections, or are vaccine preventable infections also a significant problem in this population? So in order to answer this question, my team used a national database called the Pediatric Health Information System, or PHIS dataset, that collects inpatient data on children across the United States. And so we actually looked at around 7,000 children who underwent heart, liver, lung, kidney, bowel transplant between 2004 and 2011 to see how many of them ended up in the hospital in their first 5 years after transplant with something that we would classify as a vaccine preventable infection. And what we found was really upsetting. So we found that 1 in 6 children who undergo solid organ transplant ends up in the hospital in the first 5 years after transplant with something that was potentially preventable by vaccines. Transplant hospitalizations that are complicated by a vaccine preventable infection end up being $120,000 more expensive and result in the child needing to stay in the hospital for 30 additional days. Additionally, we found that when children are hospitalized with a vaccine-preventable infection, they have increased risk of morbidity and mortality. And these numbers are an underestimate. So I want to remind you that this is just looking at children who are hospitalized with a vaccine-preventable infection. This doesn't even look at the child who had influenza or chickenpox who was able to be managed at home or in the emergency department. This is solely in the hospital, and it's 1 in 6 children. So this is a real problem. What infections are we specifically talking about? So we're talking about chickenpox or the varicella virus, respiratory syncytial virus or RSV, human papillomavirus or HPV, pertussis or whooping cough, influenza, rotavirus, pneumococcus, meningococcus, and something that used to really not be a problem in the United States, but is having pandemics, both nationally and internationally now, the measles virus. So we use data from the Centers for Disease Control, the CDC, to compare rates of hospitalization in the first year after transplant to rates of hospitalization in the general pediatric population, so all healthy children in the United States. You can see that the rates of illness were so much greater in the transplant population. Children were hospitalized 87 times more for rotavirus, which is a diarrheal illness, if they underwent transplant. 50 times more likely for influenza to be hospitalized. 6 times more likely to be hospitalized for the RSV virus, and 2 times as commonly hospitalized for pneumococcus, which is a lung infection that causes pneumonia. Next, we use that same CDC data to compare what we call case fatality or death rate for certain infections in the transplant population compared to healthy children. And you can see that again, these are much greater in the transplant population. If a transplant child is hospitalized with RSV, they have 43 times more likely chance of passing away. Rotavirus in a transplant population, 27 times more fatal. Pneumococcus, 13 times more fatal. And influenza, 3 times the death rate in transplant children. So these vaccine preventable infections are causing significant problems, significant morbidity, significant costs, and significant deaths in the transplant population. A little bit more about 2 infections that can hurt our transplant recipients as they go into later life and adulthood. So this was a study by Dr. Kumar et al. Looking at pediatric and adult transplant recipients when the H1N1 influenza was going on in 2009. So they looked at laboratory confirmed cases of H1N1 in transplant populations. So they found 237 cases. 71% of those patients had to be admitted to the hospital. They could not manage their H1N1 at home. 16% required admission to the intensive care unit. 9% had to be intubated and put on a ventilator, and 4% died. So this just shows that, again, transplant recipients are at risk for these infections and then are at risk for having more serious outcomes. Human papillomavirus, or HPV, is something that we don't often think about in childhood, but need to. So Madeline et al. Did a study of 187,000 transplant recipients and found that the rates of HPV-induced cancer in transplant recipients were so much greater, and you can see the numbers below. So this is an infection that we really need to be worried about and think about how we can use vaccines to help keep our kids safe. So what can we do to make sure that our children don't get these vaccine preventable infections? The key point is that immunizations should be started as early as possible before transplant. So we know that any vaccine is going to be more likely to be effective before you put a child on those immunosuppressing medications after transplant. We actually know that even before transplant, kids will respond better to vaccines before they get severely ill. So for example, if you can give a vaccine to a child with liver disease before they have frank cirrhosis or scarring, they will mount a better protective response. And so really my goal and my message to all families and providers is that we need to be thinking about immunizations early, not just at the transplant evaluation, but all the way in the beginning when somebody gets diagnosed with a disease that can lead to transplant. We want to be thinking about vaccines as an important part of their care. We also can follow the CDC's accelerated schedule for vaccines in the children that we know are going to be coming up for transplant. So I've shown that here, and it's a busy chart, and your pediatricians and transplant teams and infectious disease doctors know these really well. But I want to highlight a couple of things that can be different for transplant patients. So MMR, which is the measles, mumps, and rubella vaccine, and varicella, which is the chickenpox vaccine, can be given to a child as early as 6 months of age. You don't have to wait until 1 year to give those vaccines. And this is really important because these are what we call live vaccines, and we don't always give them right away after transplant or at all after transplant. So it's crucial to get them in before the time of transplant. Likewise, the HPV vaccine or human papillomavirus vaccine that I just alluded to in the prior slide can be given as early as 9 years of age. You don't have to wait until 11 years of age. After transplant, vaccines need to continue. And I think this falls off as children become well and they're not seeing the doctor as much, is that we forget that they really need to stay on target for vaccines because they're still on those immune quieting medicines that are going to make them more at risk for infections. So most centers will restart the inactive vaccines 3 to 6 months after transplant. Flu vaccine can even be given during the transplant hospitalization if your child is transplanted during active flu season. And myself and Laura Danziger-Isakov are doing some interesting work right now to look at if live vaccines against measles, mumps, rubella, and varicella can actually be given post-transplant. And we're finding that if a child is 1 year after transplant and on low dose immunosuppression, that they actually should be considered as candidates for live vaccines. And I'm happy to answer more questions about that if people want in the Q&A session. In terms of COVID, we recommend that all transplant candidates, household contacts, living donors, and recipients who are greater than 6 months of age should receive their COVID vaccine. Ideally, a child would receive their COVID vaccine at least 2 to 4 weeks before they go into transplant. But if that doesn't happen, then a transplant recipient can receive a COVID vaccine as early as 1 month post-transplant. It's also really important that we develop what I like to call a cocoon of immunity around our transplant children. So we want all family members and household contacts and those people who the child is going to be spending a lot of time with to be up to date on their immunizations so that they don't get sick and pass it on to the transplant recipient. And this would include making sure that adults have their yearly flu and are up to date on their COVID vaccines. It's exciting to think about what new vaccines might be on the horizon. And so work is being done to develop an RSV vaccine, a cytomegalovirus or CMV vaccine, and a more effective and powerful meningococcal vaccine. I want to talk a little bit about if we're doing a good job immunizing our transplant candidates and recipients. And this data is really upsetting to me. So we did a study where we collected all the immunization records on the day of transplant for every single child across America who underwent liver transplant, not for acute liver failure, over a 1 year period. And we evaluated whether they were up to date on age-appropriate vaccines using 3 categories. So the first category is the National Immunization Survey criteria, which just means that they got 7 basic childhood shots. The next category is standard CDC vaccines. So that would be the vaccines that we would recommend to any healthy child across America. And then accelerated vaccines. So that would be giving the MMR and VZV early at 6 months, like I talked about, and the human papillomavirus early at 9 years, as I talked about. So look how upsetting this is. Just the 7 minimum vaccines, only 55% of liver transplant recipients were up to date. Standard CDC vaccine schedule, which we use for all kids across America, less than a third of our transplant recipients were up to date. And the accelerated vaccine schedule, which I would argue should be used for every single child who's approaching transplant, 19%. So we are not doing a good job of making sure that our kids are protected against these vaccine preventable infections. I thought to myself, maybe it's just like one vaccine that people just forget about. But of the children who were not up to date, over half of them were missing 4 or more vaccines. So we're really not making sure that our kids are getting all of those vaccines that will provide them with good protection. And we did analysis to see, is it just the little babies, or is it just a certain group of transplant recipients that's not getting vaccinated? And it was uniform across all groups. We have work to do. Let's compare our transplant recipients to the healthy individuals. And remember, our transplant kids are more at risk for getting infections. So we would think that we would do a better job vaccinating them and making sure that they're protected. Only 55% of liver transplant recipients were up to date on those 7 minimum vaccines, compared to 70% of their healthy counterparts. Liver transplant recipients had lower vaccine rates than healthy children for every single one of those 7 minimally required vaccines. And during flu season, less liver transplant recipients received a flu vaccine than healthy children. It's not just the pediatric liver transplant population that's not doing well with vaccines. Only 62% of adult lung transplant recipients received their pneumococcal vaccine. Only 52% of adult transplant recipients received a flu shot. And less than 10% of pediatric kidney transplant recipients had received the PPSV23 vaccine. So across transplant, we have work to be done to make sure that we give our kids all of the vaccines that are going to prevent them from being those children who end up back in the hospital after transplant with something that could have been prevented. So we're not doing a good job. Why is this? What are the barriers? My team over the last 5 years has conducted interviews with multiple transplant stakeholders. So we've interviewed parents like yourself who have been through transplant with their own child, primary care doctors who have taken care of a pediatric transplant recipient, transplant nurses, transplant pharmacists, transplant ID doctors, and then pediatric heart, liver, and kidney doctors. And what did we find? We found that there were 4 barriers that were common across all organ types and across all of the different centers across the United States. There are gaps in people's knowledge about safety, efficacy, and timing of vaccines before and after transplant. Because there's such a large team of people who are taking care of transplant patients, sometimes there's a lack of communication, coordination, and follow-up about vaccines. So everyone thinks that everyone else is giving the vaccines and checking on the vaccines, and no one's taking responsibility for that job. Unfortunately, in the United States, there's not a centralized vaccine record that all providers can look at. So many times the liver doctor or the heart doctor or the kidney doctor cannot even access the child's vaccine records. And then there's a real problem before transplant that liver clinic and heart clinic and kidney clinic are serving as the medical home for the child, but are not used to or even able to provide vaccines that are standardly given in primary care practice. So knowing those barriers, my team developed a phone app that hopefully can address some of those barriers. So it provides education about vaccine safety, efficacy, and timing. There are some interesting data sheets that are within the app. It stores all of the child's vaccine records so that everybody can see them. There's a chat feature so that the transplant team, the parent, and the primary care doctor can all communicate. We don't have to do a phone tag where we're trying to chase each other down. And then most importantly, the app actually can keep track of whether your child is overdue for any vaccines. And it will send a text message or an email or an app alert to the parent, the primary care doctor, and the transplant team whenever the child becomes overdue for a vaccine. And currently we're trying out this app in a research setting. We're inviting all families across the country who are awaiting heart, liver, or kidney transplant to join us in trying this out and seeing if we can bring up those rates of children being up to date for vaccines on the day of their transplant. And if any of you on the call are interested in participating in that, I'm happy to give you my email and to get you set up with that research project. So in conclusion, vaccine preventable infections cause significant morbidity and mortality in the transplant population. Vaccines should be seen as a critical part of both pre-transplant and post-transplant care. And my goal, our goal as a transplant community, should be that all transplant candidates and recipients are up to date at all time points on age-appropriate vaccines. Thank you, and I'm excited to answer any questions that you might have.
Awesome. Thank you, Dr. Feldman. There was so much information in there, and that app sounds amazing. So we have a couple of questions. I think this first one, I've heard that some transplant centers are now giving live vaccines to transplant patients. Is this true? And why is this now possible?
Yes, great question. And I'm so glad you asked that because it's something that's really important to me. So first, I just want to say pre-transplant, there is a thought that you should wait a month after giving a live vaccine before heading into transplant. So the standard of care is that if your child needs to go to transplant immediately, that they wouldn't receive their chickenpox and measles shots. But if they have a month to go and they're greater than 6 months of age, then definitely we want them to get it in. After transplant, historically, the statement was that a child should never receive a live vaccine because of a theoretical risk that while being on immune quieting medicines, they might get sick with vaccine strain virus. Unfortunately, with measles and mumps and chickenpox going on in epidemic rates across the country, we had to ask ourselves, were we really doing kids a favor to say that they could never get their live vaccines? And so I'm excited to tell you guys about data that's not even published yet, but we have actually given live vaccines to almost 300 transplant recipients, pediatric transplant recipients at about 20 centers across the United States. We found that it's safe. Nobody developed measles, nobody developed graft rejection, and that the majority of patients actually mount a protective response. And so this is really a practice that is changing. And I would definitely encourage everybody to talk to their center about whether their child is an appropriate candidate for this.
Awesome. And I'll say my child is one of those. We've gotten him vaccinated and I jumped for joy. So thank you for all of that.
It's a peace of mind to know. I think people are really worried, particularly about measles, because it has a very high fatality rate. If you get measles and you're immunocompromised, the fatality rate can be as great as 50%. And so I think parents worry, you know, my child is well now. They're going to go to Disneyland. They're going to fly to Europe with their high school trip. I want them to live a regular life. And so this is really something to think about to give peace of mind that they will be safe against these infections.
I totally agree. So we have two more, and I know we're kind of running down on time. So for something like HPV, if the child has been transplanted before the minimum age, would you recommend getting the vaccine earlier or just on the normal schedule, assuming the level of immunosuppression would be at the same at the accelerated time versus normal scheduled time?
Yeah, that's a great question. I think that your child certainly, if they're after transplant and they're not on huge amounts of immunosuppression, then they could certainly receive their HPV early at 9 years of age. There's no harm in doing that.
And that kind of leads us into the last question, which might be a little bit loaded for you, but what is considered low dose immunosuppressant?
Yeah, so that's a great question. So the Infectious Disease Society of America and other experts have put out some recommendations, but I will say that each center has their own criteria. So in general, low dose immunosuppression is that you are on either one or maybe two agents, that your trough levels for Tacro and Sero are less than 8, maybe even less than 6, and certainly that you haven't received any biologics or any thymoglobulin recently. And if people are interested in more specifics, you absolutely can email me. I can send you the articles and a little bit more granular data about that. And I guess before we conclude, I just want to say out loud, and maybe Melissa can circulate this, but my email is amy.feldman, so my full name, at childrenscolorado.org, so one word. And I am always happy to receive patient questions about any sort of vaccine or vaccine preventable infection related question.
Perfect, thank you. Yes, and I think someone put it into the chat. So blow up her email, guys. Awesome. Well, thank you so much, Dr. Feldman. It's again always a pleasure, and I guess we'll probably see you in clinic in a couple of months. But we appreciate your time and all that wonderful information on vaccines, because yeah, as post-transplant, it's a big deal for our community. So we really appreciate it.
Absolutely, it is my privilege, and I really want to thank all the families out there for all of your efforts to improve access to transplant and education about transplant, and your commitment to working alongside with us to get every child the transplant that they need. And it's really been a privilege to get to talk today.
Thank you.